examine a patient's nerves. Did you even wash your hands? Students. Right, come on then, let's start again. After introducing yourself to the patient and gaining consent, expose the patient from the waist up. Now, recount to yourself, is the physician really so cool? Look at the patient first. Are there any scars, atrophies, tremors or fasciculations? Also, look for any clues from the examiner. A lonely tendon hammer is a sure sign you'll be asked to test reflexes fairly soon.
You can confirm muscle wasting using a tape measure. A pill-rolling tremor at rest is a sign of Parkinson's disease.
Before testing for tone, inquire about pain and then ask the patient to relax. Now, grasp their hand as if you were greeting them once again. Smoothly move the appendage at the wrist, elbow and shoulder joints. Abnormal tone can be described as clasp knife, lead pipe or cogwheel. Excellent, Ethel, but don't forget to test both upper limbs in turn.
Clasp knife spasticity is where movement is initially very stiff and then suddenly becomes loose. Lead pipe rigidity is sustained resistance to movement, often seen in Parkinson's patients. Alternatively, they may have a superimposed tremor. This materialises as cogwheeling.
Test power by asking the patient to perform these movements against resistance.
You okay? Now arms by your sides. I'm going to pull down resistance and push against me. Okay. And pull back. And push up against me. Now if you could spread your fingers out like that. And thumbs up to the sky. I'm going to push down.
Very good, Ethel. Power is graded using the MRC grading system, where grade 0 is no movement at all, and grade 5 is full power. There are only 3 reflexes that a medical student need concern themselves with in the upper limb, so even Ethel can remember them. Right, let's recap. Grasp the tendon hammer thus. Good. Now, ask the patient to relax, and with movement at the wrist only, let the tendon hammer fall onto the relevant tendon. If no reflex is observed, ask the patient to clench their teeth and then stroke the tendon. This is called reinforcement. We need to test light touch and pinprick sensation followed by vibration. Taking a piece of cotton wool, use the chest as a point of reference for the patient. Then, ask the patient if it feels the same in each dermatome on both sides. The dermatomes of the upper limb are C5, C6, C7, C8, T1 and T2. Repeat this using a neurotip, disposing of it in the sharp spin afterwards, of course.
Light touch and pain are carried in the spinothalamic tract of the spinal cord.
Use a 128 Hz tuning fork to test for vibration sense at the bony prominences. If the patient feels the vibration at the thumb, this is normal. You may wish to say that you would use the fork to test other bony prominences and also use it to test for temperature, but you would move on. To test proprioception, show the patient movement of their distal phalanx up and down. Then, ask them to close their eyes and tell you which way you move the appendage.
Up.
And remember, test both sides, Ethel.
And now the other hand. Vibration sense is carried in the dorsal column pathway of the spinal cord.
Nearly there now, Ethel. Next is coordination. This is tested for by asking the patient to touch your finger and then their nose, continuing to do so as you move your finger from side to side. Be sure to notice any intention tremor, Ethel. That's a sign of cerebellar disease. Another sign of cerebellar disease is dystiodocokinesia. This is tested for by asking the patient to perform rapid alternating movements, like so. Finally, ask the patient to stand. Reassure him or her that you are there for support should it be needed, and ask them to close their eyes. If the patient becomes unsteady, a lesion of proprioception is likely. This is a positive Romberg's test. You may also wish to test for pronated drift here. Ask the patient to hold out supinated arms and then close their eyes. The arms may appear to pronate. This is a sign of upper motor neuron lesions. Once you've finished, thank the patient and tell the examiner you would like to perform a neurological examination of the lower limb, assess gait, and perform a peripheral vascular examination. Okay, 4 marks for effort, Ethel, but OSCEs are also about sounding fly. Like this. Miss Visser is comfortable at rest and has no peripheral signs of neurological disease other than atrophy of the hypothena eminence and perhaps some mild clawing of the left hand. Tone, power and reflexes are all normal and grade 5 bilaterally, save for grade 4 abduction of the left fingers. Fine touch and pinprick sensations are lost over the hypothena eminence and medial 1.5 digits. Coordination is normal. This is suggestive of a left ulnar nerve lesion. You must be prepared to briefly talk about the causes, signs and investigations of neurological pathology, for example, peripheral neuropathies, radiculopathies and CNS diseases.
Glove and stocking sensory loss is characteristic of peripheral neuropathies.
Well, Ethel, I hope you've learned something today, and if you have, bravo! And if you haven't, well, it's your fault for not listening well enough, and I won't be held responsible for any mistakes you make in the future. Good luck on the wards! Bye, everyone.